Okay, so this is for anomalous left coronary artery. It's an abnormal left coronary artery that's coming from the pulmonary artery instead of the aorta. So this is the right side of the heart, the left side of the heart. This is our superior vena cava, and this down here should be the inferior vena cava. But this is the outside view of the heart where our coronary arteries are. This red one is our aorta. This blue one right here is our pulmonary arteries going to the left and going to the right. These are our coronaries that in a normal heart should both come from the aorta. So the other one should be on the aorta, on the right and the left of the aorta. But in an anomalous left coronary artery, it branches out from the pulmonary artery. So as we know from nursing school that our coronary arteries oxygenate the muscles of the heart. And if it's coming from the pulmonary artery, this is desaturated blood that's circulating now and giving blood to our muscles of the heart, which is not a good thing because we want to have oxygen-rich blood giving the energy for our heart to actually do its purpose. So that's the definition of that. According to this book that I'm using and the website that I looked at, 10 to 15% are not adversely symptomatic. I mean, they might still have symptoms, but it's not as severe until they reach adolescence. This is because the heart compensates and makes collaterals, makes like connections. Do one more. Okay. It makes connections. So, yep. When arising from the right aortic sinus, the left coronary can course either posterior to the aorta, in between the aorta. What? Oh, so it's just saying that this what do you call it? The coronary artery, the right coronary artery, is coming from the right aortic sinus, which is that sinus over there on the right side of the aorta, and then the left normal coronary artery should be coming from the left aortic sinus, left aortic sinus. And however, it can go from different, it can take different routes. This is the top view of the heart. If we're facing our heart and we look from the top, like a drone view, top view, a bird's eye view, we will see our pulmonary artery and our aorta are oriented this way. So in our wrong, malformed, anomalous left coronary artery, the left coronary artery branches out from the pulmonary artery right here, and the right coronary artery is normal in the aortic coronary sinus. Second view is that our left coronary artery is coming from the aorta. Oh, let me explain this. I'm sorry. I'm discussing anomalous left coronary artery branching from pulmonary artery before. This is that. It could also be branching from the aorta, but it's taking a different route, which is going in between the pulmonary artery, or taking this route around the pulmonary artery. When this coronary artery courses in between, its ostia is frequently slit-like and stenotic. I do not know what it means, but I'm going to skip that. In patients with pulmonary arterial origin, Okay, the left ventricular myocardium is usually deoxygenated and inadequately perfused with a lower driving pressure. Of course, because our aorta, like I said in the first video, shoots out, and then the afterload is what fills the arteries here. Here, the pulmonary artery doesn't have as much pressure as the aorta. As a matter of fact, the blood pressure in the pulmonary artery is 3 times lower than that of the aorta. That is according to pted.org that I'm using to study. So when that happens, this is the arteries which branches out from the pulmonary artery, coronary arteries, would also have lower pressure. This leads to ischemia, and so ischemia, which means we don't get blood there, and is that left ischemia and dilated cardiomyopathy. So we can say that the ventricles are dilated. I'm not going to draw that anymore. So it may be further compromise the perfusion, the myocardial perfusion is what we're talking about here. This is our main concern with this kind of defect, myocardial perfusion. So with the myocardial perfusion may further be compromised due to the collaterals, which is this 3 here connection, because the higher pressure right coronary artery stealing flow from the myocardium and shunting into pulmonary artery. Okay, so what it does is this has higher pressure. The pressure is higher here. And this side has lower pressure because, like we said, it's from the aorta, and this one is from the pulmonary artery. So if that's the case, the blood that is traveling from here all the way down also travels to the collaterals, which pushes our low pressure, higher pressure wins. It pushes that low pressure back to the pulmonary artery. So instead of getting the blood flow here, the desaturated, whatever oxygen it had, the desaturated blood, instead of getting that little desaturated oxygen, it even steals the blood away from the coronary artery, cutting out the actual perfusion in that area. So it goes back out. So our oxygenated blood goes the wrong way. It goes back out. That is stealing the blood away from the coronary system to the left coronary system. So signs and symptoms for our pediatric population is decrease in feeding, irritability, heart attack, in first year of life. That's so inpatient right aortic sinus. So in patients with this case, where the left coronary artery comes from the right aortic sinus, this is right aortic sinus. It's coming from the right aortic sinus. It goes between the pulmonary artery and the aorta, and it may cause dynamic compression, and it can be associated with chest pain induced by exertion. How do you spell exertion? Well, exercise, induced by exercise, and sudden cardiac death. Sudden cardiac death. Because this is compressed, cutting out the circulation. Even though it's oxygenated, it still cuts it out. So that is one of our anomalous. Left coronary artery. Passage of the left coronary artery anterior to the pulmonary valve is a risk factor for tetralogy of Fallot. So on this case now, this one is the desaturation. This first drawing here, the first one. The second drawing is the compression. The complication is the compression. And then the third drawing here in the bottom is, this is a risk factor for tetralogy of Fallot, which is TOF. Other signs and symptoms that I found using that same website that I told you all about earlier, which is the pted.org, are heart palpitations, mitral valve regurgitation, chest pain induced by exercise or chest pain from exertion, dyspnea, difficulty, systolic heart murmur, pain in breathing, systolic heart murmur, or like we said, the sudden death. These are our signs and symptoms. My board is terrible, but whatever. Diagnosis. How do we diagnose this? It can be suggested by our EKG, ECG, or EKG reading, and with that we know that ischemia is seen on our EKG strips as ST elevation, ST depression, or what was that? T wave inversion. Okay. Yep. So going back, reviewing everything, ischemia, this coming from the pulmonary artery, it can cause desaturation or ischemia. It may also cause dilated cardiomyopathy because of the ischemia. Collaterals are formed by the body to try to compensate, but this is also not good because it steals and shunts the myocardial perfusion from right to left, but since it's higher pressure on this side and lower pressure on this side, it shoots back up to the pulmonary artery, stealing the blood flow, cutting it off here, so we're not getting that blood flow. It's probably the way I drew it, but in the book it's angled differently because I am thinking, well, why didn't it shoot down instead of shoot up? But the book's drawing is more like that, like angled up. So with that high pressure, it shoots out towards the pulmonary artery instead of going down. So that's how it steals the blood. So we have the collaterals, the shunting from right, left to the pulmonary artery. Therapy. Currently for this pulmonary artery origin, there's a surgical ligation at the pulmonary side. They ligate it and put it somewhere else. There's well, I'm sorry, that was not what I meant. The reimplantation is where they cut it and connect it to the aorta. That's the reimplantation. So I'm gonna write it down here. Can y'all see that? Yep. This part you can see, huh? Treatments. Surgical ligation. And then at pulmonary side, surgical ligation at pulmonary side, reimplantation. This is when we move this to here to the aorta. Tunneling of the left coronary artery is performed. This is called the, I don't know how to say this, Takeuchi, Takeuchi procedure. In this procedure, they tunnel across the interior of the pulmonary artery that carries blood from the aorta to the left coronary artery. Huh. I'm not sure what this means. I'll leave it all to you guys to look up. But it's called Takeuchi procedure. I'm not going to go that dwelling that deep into this topic, but that's one of the treatments for pulmonary artery origin of the anomalous left coronary artery. Let's see what else. For anomalous origin of the right coronary artery or left coronary artery, the vessel can either be tunneled or reimplanted, or it can be bypassed with a mammary graft. So that's what the book says. So what's that? So for this part, it says the left coronary artery arises from the pulmonary artery. The second one, the left coronary artery arises from the right aortic sinus, which is on the right side, and passes between the aorta and the pulmonary artery. So, like we said, it could be constricted and compressed. On the third picture, left coronary artery arises from the right aortic sinus and passes anterior to the pulmonary artery. So this is the anterior part, and this is the posterior part. Yeah, that's it. So that is that. Nursing interventions. Let me think. Nursing. What do you do, my fellow RNs? Nursing, we watch for our EKG strips. We monitor for our pain assessment, chest pain. Desaturations, myocardial perfusions. Our babies will have difficulty feeding, irritability, and the murmur. They may have the murmur, systolic murmur, because of the mitral valve regurgitation. Also, I read it somewhere. It's either the book or that website that mitral valve regurgitation may persist after surgery, but sometimes it may after repair, but it goes away on its own sometimes. But if it doesn't, then they would have to go and do a separate surgery for that specific problem, the mitral valve regurgitation. Interesting fact. When I first started on my unit, I was so used for med-surg when an adult would come in for, let's say, GI bleed, and that was the only diagnosis, and the rest of his problem was history or like comorbidity, like diabetes or whatnot. But the actual problem right now is just GI bleed, for example. However, for what I'm experiencing now, my patients come in for, say, anomalous left coronary artery, VSD, mitral valve regurgitation, or something else. But it's all like a bunch of stuff all together. And at first, I thought it was like, oh, maybe because, they didn't develop right. That's probably why they had all these problems. But one of my very good preceptors explained to me that actually these things are not just like, does not occur independently or because they are there. It's because they are related to the actual problem, such as what was I saying? Oh, for this one, anomalous left coronary artery, for example, they may have mitral valve regurgitation, and that's because it's in the same, it's the same diagnosis. Or a better example would be for a pulmonary artery stenosis. Pulmonary artery stenosis would obstruct the blood flow to the pulmonary arteries out from the right ventricle. So we can get a VSD on top of that. So these are not just random stuff thrown together because the body is not developed right. It's actually sometimes a way for our fetal body to compensate, is what they told me. So since our right ventricle can't pump blood to our aorta, to our pulmonary artery because of that stenosis or a blockage, anything blocking that way, it might produce a VSD, a ventricular septal defect, to bypass pulmonary artery and flow to this part, to the left side of the heart. I just found that interesting. So that is it for anomalous left coronary artery.